Thank you, Bernard, for your time and your visit to Chile. My first question is, what is the main purpose of your visit to Chile, and what expectations do you have regarding your collaboration with CCAN?
I came here because we have this collaboration with Nicolas and CCAN for quite a while. I'd advised them a bit when they started the grant application mostly on the cancer survival and the inequalities. And then the expectation is first that they are able to replicate or to carry out the study on inequalities, and then to continue collaboration, because international collaboration are really important. I think I can learn a lot from what they do.
Bernard, what inspired you to focus on inequalities in cancer outcomes?
I would say first it's inequalities. I've always been interested in inequalities and why we observe inequalities. And cancer outcomes, it was more because the data was there than it was the cancer. But I was interested in the inequalities in care and the outcomes from care within the healthcare systems where there's universal health coverage. Then in theory, we shouldn't see inequalities because everyone has the same access to care. But in practice, we see a lot of inequalities, even when we account for individual factors. We are all different, but we still see the differences, then inequalities. And I want to understand why.
And even in Europe, because sometimes we think that Chile is like...
Then the big difference, for example, if we compare to the US, of course, they don't have a full, and it was even more true before the Obamacare. Then they have this problem of inequalities in terms of they don't have universal health coverage like we have in Europe. But we see still in Europe wide inequalities, and in particular in the UK where we work. And the universal health coverage removed the financial or large part of the financial issues due to the cost of care, etc. But still we see inequalities in access to care and in the use of care. And that's something quite shocking in a way for a system which is based on equity.
Your recent research has integrated interdisciplinary approaches to evaluate the impact of policies on cancer inequalities. So could you share examples of policies that have been proven effective in reducing these inequalities, and maybe how they could be adapted to Chile healthcare system?
Then unfortunately I don't have any example so far, except that, but I'm not the best place for that. I think in New Zealand they do currently they do a lot of and very interesting work to integrate underserved, marginalized population, then more likely to experience inequalities, and to do a comprehensive, to use a comprehensive approach to tackle the inequalities. The interdisciplinary, why I'm interested in that, it's different from multidisciplinary. I wouldn't like to have a program of research where we have, I don't know, qualitative researchers, quantitative researchers doing their own studies in parallel, talking to each other, but that's all. I would prefer what I mean by interdisciplinary. From the beginning, we try to see how we can collaborate and how we can complement each other. And the program we have developed, and I think second is really good for that. It's from the beginning, what I understand. It's really, we really try to work together, and then when we have studies, we do the qualitative, and then the qualitative is asking the quantitative, can you complement this, and vice versa. Exactly. And I think it's much more rewarding and satisfying, and we can learn much more from that.
Well, as you said in second, that's what we are doing or trying to do. Sometimes it's not that easy, but we're working on it.
It's not easy because it's more challenging because we don't, well, we speak the same language or English, or, but the meaning of the words, they're not the same. And sometimes it's very hard to communicate,
Yeah.
but it's also the reason we work quite closely with, well, I'm a quantitative researcher, then we work closely with anthropologists, etc. And we try really to meet, well, we are in the same department now, then we can discuss every day with them, and I think we have made some progress.
It's
we
working.
understand a bit better each other.
Bernard, patient and public engagement has become central to your research. What strategies would you recommend to involve the community in cancer prevention and control in Chile?
Yeah, then that's an excellent point. I don't have any magic solution. I would say it's crucial we gain the trust of the people, then of this population. They are very often they see some researchers coming, taking some data from them, and then disappearing. Then from the beginning, first we need to establish long-term engagement, involvement with them, but also to be very clear in terms of what are the aims and the benefits from both sides. Then if we are clear with that, I think we can do a lot of work and we can hear what they say and then involve them. We are not asking them to become a statistician, etc. That's not the case. It's not that. It's really to involve them in even implementing, developing and implementing the intervention policies, which usually aim to reduce the inequalities, but sometimes the effect is the opposite, or it has no effect at all because we haven't really listened to them and to what are the causes of these inequalities.
Bernard, we know you have worked on developing and refining analytical methods to address research questions and communicate findings to policymakers. What tools do you consider essential for countries like Chile to effectively monitor and address health inequalities?
Wow, I don't know. That's a very difficult question.
It is.
I don't think there's one tool. I can give you maybe one example. I would say it's one success we had with the policymakers and politicians, I would say, or the people in power. It's a tool, a very simple tool we developed. We call this Cancer Survival Index, and it was used to help the policymakers to monitor their progress or their performance in cancer management at the local level. Then England is there's a health administration, administrative geographies, and then it was to help them. And not only we developed this index, but we developed two tools. One, it was some maps showing with some colors how it evolved with time in terms of performance. Then we could see in red where it didn't work, the progress. And also another tool, it's technical, it's funnel plots, but where the people, the local people, could see if they are outliers, and then it was not to shame them, but then to start studies locally to try to understand why they didn't do well. Then it could be about survival, but it could be probability to treat patients, etc. Then that was quite well received locally because they had something, a tool they could compare to the national average and say, okay, what are we doing wrong? Is it a problem in our population? Then outside the remit of the healthcare system, or is it something they're doing wrong, on the pathway, etc. Then I think they really like the tool, and it has been implemented by the NHS within their dashboard, the cancer dashboard.
Bernard, at the beginning you said that international collaboration, it was important. Why do you think it's important, and what opportunities do you see for closer cooperation between CCAN and ICON?
Then, as we don't fully understand the inequalities in cancer care, in cancer outcomes, and one approach I always said it's really important is to do international collaboration, not to compare but to contrast what happened. Then we look at the inequalities, we try to understand why it's different, we try to really decipher the different route to care, the treatment, the outcome, and really contrasting the systems, and to try to understand, can we learn from each other? Then we try actually to collaborate, to have international grants with Chile, South Africa. At that time I had Chile, South Africa, China, cannot remember another country, really to have different systems and to see how we can learn from each other. I did this quite a lot with Japan and France, to try to understand the system. It's all universal health coverage system, but with different issues. And I think we really can learn a lot. Then I hope we can continue and even widen the collaboration we do with CCAN, and I think we will. We have very good.
I hope so.
We have really good contact, etc. Then and we have we share a good spirit. Quite open. Then I think we will quite easily.
Okay. Bernard, and finally, maybe looking to the camera, what message would you like to share with the healthcare professionals, researchers, and policymakers in Chile working on cancer prevention and control?
I had some discussion with some of the people in charge or senior people in CCAN, etc. And I don't think you are far. You will learn very quickly, and you will be very quickly with a quite comprehensive program. I think we will learn from you very soon. I see you do already a lot of interdisciplinary involvement of communities, patients. I think it's already great. I see that we can. Then I wouldn't say, because there was this worry, we have so much to catch up. I don't think so. You already.
So we're in a good path. Right?
Yes. Yeah. I'm really. I have no worries.
Okay.
About that.
That's
yeah.
good.
Yeah.
I'm glad to hear that. Okay. Thank you so much, Bernard.
Thank you.